So good evening, everyone. Welcome to what I think is our 8th VCCC breast cancer education series. We think we've got a cracking topic tonight, so we hope that you'll be entertained, learn something, and please interact with us. I think everyone knows how to get in touch with us through the Q&A function and also the chat function, and feel free to enter any questions or comments you may have throughout the talks we've got today. We've got 3 fantastic speakers and 2 guest panelists, so I thank them all for joining us on a topic that, you know, certainly we discuss in our MDM, it feels like on a weekly basis, and that's oligometastatic breast cancer. So Rachel's going to kick us off to really open the topic from a medical oncology point of view. Yang is then going to talk about the surgical considerations, and we've got Janice closing with the really interesting radiotherapy aspects of this topic. And we've got Michael Chow and Kathy Poloness to join us for a panel discussion, and Bruce may chime in, I suspect, at the end as well. So for today's presentation, we're going to do all the talks first, and then we'll hopefully have sufficient time to chat. So thanks so much, Rachel, for starting us out.
Good evening, everyone. My name is Rachel. I'm one of the medical oncology advanced trainees here at the Austin. I'm going to start off with a case presentation. So this is a 36-year-old lady who's a health professional, who's married with 2 young children, with no family history of breast or ovarian cancer, who presented with a 1-month history of a symptomatic right breast mass, and on imaging was found to have a 4-centimetre malignant calcification in the superior aspect of right upper breast. A biopsy of the mass revealed a grade 3 invasive ductal carcinoma, so luminal B, so ER 90%, PR 10%, HER2 negative, with a relatively high Ki67 of 40%, and the FNA of the right axillary lymph node was also positive for cancer. She was referred to medical oncology essentially for a discussion of neoadjuvant therapy, had a PET scan done, a diagnosis that revealed a right ilium lytic bone metastasis, as you can see on the PET scan, as well as multiple avid axillary nodes and subpectoral nodes. So we're perhaps going to discuss further about this towards the end, but I suppose the options for this lady would be, do we treat this lady as metastatic incurable disease and offer her systemic therapy, a combination of endocrine therapy and a CDK4/6, or do we still offer her curative intent treatment, which will include neoadjuvant systemic therapy followed by surgery? And what would also be the role of radiotherapy, either adjuvantly if she goes down the surgical pathway, as well as what would the role of radiotherapy be to the right iliac bone metastases? So as we know, there's no universal definition for oligometastatic breast cancer. It describes a subgroup of patients representing up to about 10% of patients. We don't use a strict definition in clinical practice. So these are the various definitions, and I won't go into detail, but to summarize them all, a lot of the definitions include essentially 1 or 2 sites of disease, perhaps involving 5 or less metastatic lesions. And if you look at the second definition, they further divided that into whether the disease was de novo versus residual after systemic therapy versus recurrent after curative local regional therapy. And perhaps this could have implications on what treatment we offer these different groups of patients, and certainly impact on survival benefits as well. So do we offer these group of patients aggressive intent therapy, and if so, why? Do they have improved survival outcome? And I'll go through shortly a couple of more so retrospective studies and systematic reviews looking at the variable survival outcomes of this group of patients. The factors that we found contributed to improved prognostic outcomes, as we may know, is solitary metastases, a longer interval between primary tumour and oligometastatic disease, no or limited involved axillary lymph nodes at primary diagnosis, and hormone receptor positivity. mean, some of these patients could possibly have good disease-free survival, particularly patients with hormone receptor positive diseases. They can remain on first or second line systemic therapy for a long time. And perhaps with less tumor burden, these patients are less symptomatic, so they are perhaps more fit to then handle aggressive or curative intent treatment. So have we shown that these patients live longer? So the first trial, so this is actually a study that was published in the JCO a very long time ago, basically looked at a large group of patients treated with doxorubicin, an alkylating agent, so systemic therapy that was used back then. 82% of patients then had 1 to 3 metastatic sites of disease. And this imaging was what was routinely done then, so certainly no PET scans were used then. That's something to note. And this study found that 16.6% achieved complete responses, so CR, and 3.1% remained in CR for more than 5 years. And 92% of patients, so most of them, or almost all, sorry, had 1 to 2 sites of disease at baseline. And 25% of patients had long-term CRs, with long-term CRs had a tumor burden of less than 5. So they found that in this long-term complete responder group, more patients were premenopausal, they were younger, they had lower tumor burden and better performance status. And the median overall survival in this group of patients was 46 months, which is quite impressive. But I suppose it remains unclear if the long-term survival or the good response is due to the chemotherapy that was used. I mean, obviously, they did use doxorubicin-based treatments, or the favorable disease biology of these types of tumors, or a bit of both. Now, looking at the second review, this looked at a smaller number of patients, so 75% of patients who all received systemic chemotherapy up front, and the chemotherapy used here was quite similar to the previous study, but those who achieved complete or partial response, so CR or PR, went on to get either surgery or radiotherapy to sustain or induce CR. And this was the definition that was used as an inclusion criteria, so quite a similar definition to, I suppose, what I showed at the first slide. So they excluded patients who previously received intense chemotherapy. So this would include patients who received substantial doses or intensity of anthracyclines or taxanes, as well as those who had a recurrence within 1 year after adjuvant and neoadjuvant therapy. So 59% of patients had single organ metastases, and the rest had 2 sites of disease, and none of them had brain metastases. So I suppose this group of patients were already in the group that would have had good prognostic outcomes. And 35% had luminal A, and the rest had, and 24% had basal-like cancer. So these were the more common types of cancers. And 74% had previous neoadjuvant and adjuvant therapy, suggesting that this is likely a recurrent sort of metastatic disease. So the complete response rates were higher in those who received combined modality treatment compared to systemic therapy alone, so 64 versus 48.5%. And those with 1 organ involved did better than those with 2 organ involved, and this was similar in either the systemic therapy alone groups or those who received multimodality treatment. And similarly, the median overall survival was also better in the 1 organ involvement, so 73% survival at 10 years, as well as those who received multimodality treatment, so 82% at 10 years, which is quite good. But interestingly, this review showed that patient age, disease-free interval, status of hormone receptors, which is quite surprising, and liver mets did not significantly affect the rates of complete response. This is a systematic review that was published more recently, so last year. So included a large number of abstracts, papers, and studies. And certainly the definition of oligometastatic disease varied, but in general, they had a cutoff number of lesions or sites, or they included studies that had patients where, I suppose, all lesions were amenable to local therapy. And they found that there was a large range of overall survival from 30 to 79% at 5 years, and a 5-year PFS of 25 to 57%. And this could well be due to the variable inclusion criteria and the variable definition. But what this review also found were that there were a couple of potential prognostic factors. So having a solitary metastatic lesion was a good prognostic factor, but a lot of these studies were old, so they used older imaging techniques which could have underdetected lesions, so no PET scans were used back then. And certainly patients that were perhaps not suitable for example, radiotherapy back then would have been suitable for radiotherapy now, given the improved technical abilities with machines and things like that. Secondly, a longer disease-free interval, so they came up with a number of more equal to 24 months, was a good thing. However, it was not clear from these reviews whether disease-free interval was associated with success of multimodality treatments. ER positivity was a good thing, but there was incomplete information on the ER statuses for some of these studies. HER2 positivity was a bad prognostic factor. However, we know that this has changed. A lot of these studies were old, so anti-HER2 therapy was hardly used in these studies, and we know that now we've got good options and very good responses with our anti-HER2 therapies. And there was also a note of the presence of axillary lymph node metastases. So this was a bad prognostic factor. However, the limitation to this is that it's based on complete clearance of the axilla, and we know that this has become, I suppose, more obsolete now, given that we've got better axillary staging methods as well as the use of neoadjuvant chemotherapy as well. And I suppose the other aspect that this review did not answer was whether patients who responded well to the systemic therapy did better or not, but I think there was just inadequate information on systemic therapy used. So just in the interest of time, I'll just go through this quickly. So this study essentially looked at patients, so 342 patients, and they defined long-term survivorship if you had metastatic disease-free survival of 9 years. And I just wanted to bring everyone's attention to the fourth point, which was, interestingly, it shows that age, visceral metastases, and limited number of metastatic sites at the time of diagnosis did not have an impact on long-term survival. So quite different from the results of the first two reviews. And it showed that long-term survival was also not associated with the use of chemotherapy. So there are a lot of unanswered questions. It seems to be like breast cancer, this group of oligometastatic patients are perhaps quite a heterogeneous group with variable survival outcomes. We know that a group of patients, so 30 to 40% of patients with oligometastatic disease who treated first with local therapy and go on to achieve excellent response, can start to demonstrate widespread mets within 3 months, and eventually a large number of them progress to metastatic breast cancer within 2 years. And certainly we're going to further discuss the role of local directed therapy such as surgery and radiotherapy. And I suppose the factors to consider would be, is there a subset of oligometastatic patients, say patients with solitary metastatic lesions, that we treat aggressively with curative intent treatment, as we know that these patients could achieve complete remission? Do hormone receptor and HER2 status play a part? Would you treat de novo versus recurrent oligometastatic disease differently in terms of offering systemic therapy versus systemic and local therapy? And certainly patient factors to consider as well, such as age and performance status. And thank you.
Thanks very much, Rachel. I think you've certainly opened the topic well, and clearly, the heterogeneous definition of this really creates some difficulty when you're looking at outcomes in this. So I think we're going to discuss that even more. We'll move on to Yang, our surgical fellow, who's kindly going to discuss the surgical considerations in this. Thanks, Yang.
Perfect. So my name is Yang. I'm the current breast surgery fellow at BMAC. Today I'll be presenting on the surgical discussion for patients with oligometastatic breast cancer. So today's talk will be focused on the role of surgery on primary breast and nodes, as well as surgery options for isolated metastases to contralateral axillary lymph nodes, lung, and also liver. We know that surgical discussion with the patient involves understanding of the patient's expectations, prognosis discussion with medical and radiation oncologists, and informed decision-making with treatment available. Patient and disease factors need to be taken into consideration. We've heard from Dr. Rachel Raju from a previous excellent talk about the definition of oligometastatic breast cancer. So we know about 5 to 10% of patients who present with de novo stage 4 breast cancer has an intact primary. There are currently conflicting literature evidence regarding the local management of primary breast cancer in patients with controlled disease. And there are multiple mechanisms to explain the benefits of local regional therapy. So multiple mechanisms have been proposed on why surgery on primary could improve overall survival. And these include reduced tumor burden, disruption between crosstalk between the primary tumor and metastasis, as well as restoring immunocompetence, just to name a few things. So I'll give you a clinical case example as well. I've got a 42-year-old lady who's premenopausal. She had right breast cancer diagnosed in 2018, YAPR positive, HER2 positive on DISH. She presented with de novo metastatic disease with multiple bony metastases to T-spine, ribs, ischium, and femur. She had a T5/6 decompression because of spinal compression and right hip hemiarthroplasty. She's been on maintenance, Herceptin, Perjeta, Zoladex, letrozole, and denosumab, and even had palliative radiotherapy to the breast in September last year. However, recently she's developed progression in her right breast. The patient herself describes heaviness and discomfort, and she's also on apixaban. So we know that often cases are quite challenging and not straightforward, and this is certainly an example of such patient. So are there any clinical evidence to guide us? We'll look at 4 prospective randomized controlled trials examining this question. So I'll go through each one in detail. This is a summary table summarizing 4 of the prospective randomized controlled trial. Batwi and colleagues were the first RCT commenced in 2005 in India. They recruited a total of 350 patients, randomized half to surgery and half with no surgery. All of the patients with resectable hormone-positive disease, all patients with partial or complete response after 6 to 8 cycles of anthracycline-based chemotherapy. You can see 72% of the patients had mastectomy, 23 had breast-conserving surgery with radiotherapy. All of them had some form of axillary dissection. 76% achieved clear margins, and the median follow-up is quite short, only at 23 months. The median overall survival between the surgery arm and the non-surgery arm is fairly similar at 19 to 20 months. The 2-year overall survival, again, is similar with 42 versus 43%. They did not look at any local regional progression or quality of life. Highlighted in green here is the NF0701 study, which was conducted in Turkey from 2007 to 2012, with half the patients, 138, who had local regional treatment. The patients had presented with novel stage 4 disease. None of them had any form of systemic therapy. 74% had mastectomy, 26% had breast-conserving surgery with radiotherapy, 93% had axillary dissection. They have achieved 100% R0 surgical margin. The follow-up for this study was 40 months, and 5-year survival was a clear benefit or improvement in the local regional arm, 42 versus 24%. Also important to note that the local regional progression was also lower in the surgery arm, 1% versus 11% in the non-surgery arm, with a significant p-value of 0.001. The positive study was conducted from Austria, where they looked at 90 patients in total. The trial was stopped early due to poor recruitment. Patients were included with stage 4 disease. None of them had any form of preoperative systemic therapy. The makeup of the surgical group was fairly similar to the Batwi study, and follow-up is a bit longer at 37.5 months. And however, the overall survival with surgery was shorter at 35 versus 55 months. and this was not statistically significant. Looking at local regional progression, there were 9% in the surgery arm and 18% in the non-surgery arm. Quality of life there was no difference between the two groups. Very recently, the ECOG group from USA about to publish or presented the data at the ASCO in 2020. This was the E2108 study, where patients who had presented with de novo stage 4 disease had been on systemic therapy for 4 to 8 months with no clear disease progression. And after this, patients were randomized to surgery or local regional arm and no surgery group. Within the local regional arm group, there was 87% who had either breast conserving surgery or mastectomy. 80% of surgical margin was achieved, and median follow-up was 53 months. The 3-year overall survival was 68% in both groups. And interesting to note that in the surgery arm, the local regional progression was lower at 10% versus 26%. This was statistically significant. In the surgery group, however, the quality of life was reported to be worse at 18 months, but there was no difference at 6 or 30 months. So we'll look at each study specifically briefly. The Batwood study was published in the Lancet Journal, and 18% of patients in the arm where there was no local regional therapy eventually had a palliative mastectomy. Important to note here that 31% of patients who are HER2 positive, only 8% of these received targeted therapy. And I'll just show you this is a Kaplan-Meier survival plot demonstrating similar outcome between the two groups. And in the subgroup analysis, there was no difference between surgery arm and no surgery arm. But we have to remember, as I mentioned before, only a small number of patients who receive HER2 positive targeted therapy. Next, this is the MF0701 study, which was published in the Annals of Surgical Oncology in 2018. Majority of the patients had bone-only metastasis, 46%, and about 7% of patients who did not have local regional therapy eventually require some form of local therapy. So there are quite a difference between the number in each group. You can see here in the surgery or the local regional arm, majority of patients were hormone positive. And in the triple negative group, majority of patients were received systemic therapy, not local regional therapy. And in terms of bony metastasis, it was fairly comparable between the two groups, 51% and 40%. You can see here in this study, the local regional therapy group demonstrated a clear 5-year survival benefit at 41.6% versus 24.4% in the no local regional therapy group. And subgroup analysis was quite important in this study. We can see there was, this is a forest plot, and in the forest plot, there was clear benefit in the ER/PR positive group, in the HER2 negative group, in patients who were younger, aged less than 55, and those with solitary bone metastasis only. What we could see here is patients who had multiple pulmonary or liver metastases had an overall worse outcome. So moving on to the next study, this is the positive study from Austria. This was published in the Annals of Surgery in 2019. The trial was stopped early because of poor recruitment. Again, there was quite a difference between the demographics between the two groups. In the surgery group, there were more patients who had T3 disease and N2 disease versus the non-surgery arm. So in the surgery arm, 22% patients had T3 and 15% were N2 versus 6% and 4%. The median survival was poorer in the surgical arm. So the surgical arm is the non-dotted line here. The dotted line is the the surgery arm is the non-dotted line, and the dotted line is the non-surgery arm. Subgroup analysis in this study in the forest plot did not demonstrate any benefit from surgery, but I just wanted to remind you again that there were more T3 patients and N2 patients in the surgical arm, and also this study did not study or look at any preoperative chemotherapy. The last RCT is from the E2108 group. Majority of these patients had luminal HER2 negative breast cancer. All of them had stage 4 de novo disease and been on systemic therapy for 4 to 8 months with no evidence of disease progression. 38% of patients had bone-only metastasis, and there was overall no difference in the 3-year overall survival, being 68%, which is quite high compared to the other studies. In the local regional progression outcome, however, surgery again performed better. Only 10% of patients had local regional progression versus 26% in those who did not have surgery. This had a significant p-value of 0.003. However, in the patients with metastatic triple negative breast cancer group, surgery group actually had a worse outcome and a high risk of death. As you can see here on the Kaplan-Meier curve, the overall survival was quite similar between the two groups at 3 years. There were a couple of criticisms of this study. The full results have not been published yet, but in terms of it having a quite high overall survival at 3 years, it does reduce the power of the study. There's not been any reported multivariate analysis, and subgroup analysis is missing. We know that 38% of patients had bone metastasis, but there's no further analysis. So hopefully we'll wait for the full published results. And finally, there is a meta-analysis which has been published recently in the scientific reports, and they looked at, it's a large number of patients without including the E2108 study. They looked at all the first 3 randomized control trials, plus all the retrospective study, including a large number of patients, over 220,000 patients. And from the study, they concluded that local regional therapy conferred a 30% survival benefit, but only 19% in the prospective randomized control trial. Local regional therapy was most likely to benefit patients with metastatic disease only limited to bone, those with HER2 positive disease, those patients with favorable response to primary systemic therapy, and a tumor that is resectable. But we need to remember that although this study is very large, the retrospective data are very heterogeneous, and it is quite difficult to draw a homogeneous conclusion. In terms of further studies, the Japanese group and the French group are looking at similar designs to the E2108 trial. And in the French group, they are looking at palbociclib plus letrozole with local regional therapy after 6 months of systemic therapy. So there's a couple of future studies to look forward to. So now I'll move on to the next part of the talk, which is focusing on surgery for isolated metastases. We'll be focusing on surgery for contralateral axillary disease, bone, lung, and liver. So in terms of surgical indications for isolated metastasis, really depends on whether it's emergency situation or symptomatic control for palliative reasons. Emergency indications will include corticoquinal compression, mass effects from brain metastasis, or pathological factors from bone metastasis. Patients who have good prognostic factors should be considered for surgery for isolated metastasis. And this includes patients who have good performance status, oligometastatic disease, long disease-free survival, and those with high likelihood of achieving a complete resection. So in terms of specific sites, in terms of looking at contralateral axilla, this is not uncommon, 2 to 6% incidence, and it's more commonly presenting with patients with ipsilateral breast cancer recurrence. And this may be caused by aberrant drainage to the contralateral axilla, and probably should be viewed as a regional event rather than a systemic event. Literature on this is fairly limited. There are a few small retrospective series and a few case reports. But however, recently published in the Annals of Surgical Oncology, McNamee and colleagues looked at 47 patients who had contralateral axillary metastases, and they had a curative intent with surgery and systemic therapy. Follow-up was 5 years, and overall survival was quite high, 72%. which is much better than other sites of metastasis. So really the question we ask now is, patients with contralateral axillary mets, the treatment should be with curative intent, and should contralateral axillary metastasis be treated as an M3 disease rather than a M1 disease. In terms of bony metastasis, I'll leave this for our radiation oncology colleagues to discuss in the next talk. For lung metastasis, those with symptomatic or urgent pulmonary function issues will have surgery. And also surgery, the other benefit with surgery on the lung is that it can provide some histological confirmation, which is crucial for differentials, because sometimes it could be a lung primary or it could be a colorectal metastasis or metastasis from somewhere else. So in terms of clinical evidence, there has been a meta-analysis looking at 16 retrospective studies published in the Journal of Thoracic Disease in 2015. They included about 2,000 patients, and the overall 5-year survival rate was 46% for those patients who had resection of isolated metastasis plus minus systemic therapy. And those patients with solitary lung-only mets, metastasis had a favorable prognosis. The most recent retrospective analysis was actually performed in Japan, and this is a multi-center study in Japan looking at 253 patients between 1982 to 2017. They had a median follow-up of 5 years, and overall survival for patients who had pulmonary metastatic metastasis resected had a 5-year survival of 65% and a 10-year overall survival of 50%. 22% of these patients are HER2 positive, and from their study, they concluded those patients with wedge resection or smaller segmentectomy did better versus patients who had an overall lobectomy or pneumonectomy. With lung metastasis, again, it's hard to conclude whether this is contributed by we are now having better systemic and targeted therapy. In terms of this study, there's only about 89 patients who were recruited since 2000. So not all the patients were from year 2000, and there has been some improvement in the overall systemic therapy and targeted therapy. So we don't know whether patients who experience such apparent benefit would have favorable prognosis, regardless whether they've had surgery or not. So in terms of looking at liver, so liver metastases are usually quite late development associated with disseminated disease and poorer prognosis compared to bony mets. Liver metastasis can cause pain, bleeding, and biliary obstruction. There is lack of comparative data between local therapy and local therapy with systemic therapy. And some may argue that those with isolated mets may respond better to systemic therapy, regardless whether or not they undergo surgery. In terms of local regional or in terms of surgical options for the liver, it really depends on the size and the location of the tumor. If the tumor is peripheral, then surgery can be considered. But if the liver metastasis is quite central, then we may need to look at local ablative therapy. So there's two studies looking at resectable liver metastasis for breast cancer. Both are actually from our region. One was published in 2016 in the Journal of Breast from the Adelaide group, where they looked at 956 patients, comprising of small studies between 5 to 115 patients. Overall 5-year survival of 33%. Median morbidity with surgery was 15%. And then a newer study in 2017, 1 year later, from the Auckland, New Zealand group, looked at 1,686 patients, 60% ER positive disease, 25 had HER2 positive disease. Overall survival was 36 months, and 5-year overall survival was 37%, with a 30-day post-op mortality of 0.7%. One study from this study meta-analysis was that there were one case control study with 51 patients who had concurrent systemic therapy and liver surgery. 51 patients did not have any surgery, only systemic therapy alone. They reported a three-year survival of 50% in the non-surgery cohort, whereas in the surgery cohort, the 3-year survival is quite high at 80%. Up to date, there has not been any randomized controlled trial so far. And for patients who have unresectable liver disease or
sorry, Yang, we might have to move fairly quickly through these just because we're running out of time. Is that all right? Sorry.
Yeah, no worries. Yeah, or high medical risk patients, surgery is not indicated. You may want to consider radiotherapy ablation or PACE. A couple of other future trials to look out for. And then this is a suggested algorithm looking at patients with de novo disease, metastatic breast cancer, whether there's any disease progression, if there is no local regional therapy is considered. And then those with controlled disease will be looking at whether they're symptomatic, then they will have palliative local regional therapy, or looking at biology of the cancer, whether it's HER2 positive or triple negative. HER2 positive and hormonal positive patients will be considered for local regional therapy as an option in a multidisciplinary setting. This is just another diagram to suggest the same with implementation of PET scan to restage and to monitor for progression of disease. So in conclusion, it is a multidisciplinary challenge between patients, medical and radiation oncologists and surgeons. I do think that there may be a role of surgery should be considered to control primary site progression in the context of well-controlled systemic disease, unless it's to control palliative symptoms. For patients with de novo metastatic breast cancer, I think surgery on the primary may not be as a first line, but could be considered for those with only bony metastasis, HER2 positive disease, or favorable response to systemic therapy. And lastly, surgery for isolated metastasis should be considered in a de novo setting for patients with contralateral exudative metastases and also for emergency setting, and those with low volume hepatic or pulmonary metastases. Thank you. Sorry, one more time.
Thanks very much, Yang. I know you certainly got through a lot of data there. We'll quickly move to Janice because there's certainly some discussion points coming out of your talk as well. So thanks so much, Janice, Radiation Oncology Fellow here at the ONJ.
Thanks, Belinda. I'll just share my screen. Can you see that?
Yep, we can see it and we can hear you.
Perfect. Okay, so get cracking. Thank you, everyone, for attending tonight. So my name is Janice. I'm one of the Rad-Onc Fellows at the Austin, and today my talk will be focusing on the evidence that we currently have in regards to modifying radiation therapy for patients with oligometastatic breast cancer. So before we do delve into all the evidence, I just wanted to explain that the radiotherapy technique we're most interested in this topic is stereotactic, which Yang already mentioned, stereotactic radiation therapy. So SBRT, SABR, SABR treatment, they're all interchangeable terms. And essentially, they differ from the more conventional techniques shown on the left here in regards to the prescription of higher ablative doses, usually given over a smaller number of fractions, and treatment of smaller targets with very high doses in the center, rapid fall-off of doses as we move away from the planning target volume, and utilization of stricter immobilization techniques, better image guidance, motion management, etc. So the evidence that we do currently have, before 2019, there's been quite a few single-arm, non-randomized studies, either retrospective or small prospective series, that have demonstrated advantages of ablative therapies when it comes to oligometastatic disease. However, these are understandably subject to bias given the carefully selected patient groups and a lack of control comparison. And so, unfortunately, the supporting evidence seemed to have lagged behind clinician enthusiasm and technological advances in this setting. Here is a table of the published non-randomized prospective single-arm studies of SABR in oligometastatic breast cancer that are often mentioned in literature. And I just wanted to go into a little bit more detail about the last study highlighted here, because it is a local study, the Boston study, which is done here at the Peter Mac, where we looked at, they looked at 1 to 3 bone-only metastases in the setting of a controlled primary, and the patients all received 20 gray in 1 fraction to the sites of oligometastatic disease and underwent 2-year follow-up. It was a small study. 15 patients were recruited between 2014 and 2016. And so this study, I guess, was a good one just to show in our local patient population that SABR was found to be feasible, safe, and effective, given the 100% local progression-free survival and overall survival, although it was a short follow-up of 2 years. And there were no grade 3 or 4 acute toxicities in the study. And here is a table of randomized studies that have been published in regards to metastasis-directed therapy, or MDT, for patients in oligometastatic disease, not just in breast primary. So you can see here, majority have been in other primary histologies, and the one that we do have some data for is the SABR Comet study with regards to breast primary. So also just to note, this table doesn't actually include randomized controlled trials that have been published in regards to oligo brain metastases, which did also include mixed histologies with some breast cancer patients in them. But in the interest of time, I'll be focusing on the SABR Comet study. So I'm sure a lot of us will know there's been 2 papers just recently published in regards to this study, one in 2019 in The Lancet and 2020 in JCO. So this is the first randomized trial that has been designed to directly evaluate whether eradicating oligometastases that have propagated through the systemic circulatory system improves overall survival. So the SABR Comet is a multi-center international parallel group phase 2 randomized study with patients patients with up to 5 oligometastatic lesions, and all of which were amenable to SABR treatment. And they must have had their primary tumor treated definitively 3 or more months before enrollment. And the exclusion criteria were essentially all relating to scenarios where SABR is not the appropriate treatment, or whether not doing SABR is also not appropriate. So in particular, things like spinal cord compressions and big brain lesions that needed surgical intervention, or femoral bone lesions that needed surgical prophylactic fixation or intervention. So the study, the patients were randomized to either control group or SABR intervention group in a 1:2 ratio. So in the control group, patients received standard of care, systemic therapy, as well as palliative radiotherapy as per usual. So, when there's symptoms to alleviate, or whether there's any anticipated complication of progression that would benefit from palliative radiotherapy. And the dose and fractionations that were used are quite typical palliative doses, ranging from 8 gray in 1 fractions to 30 gray in 10 fractions. And in this arm, they did specify that SABR or radical doses of radiation therapy were not allowed. However, it was interesting to note between the 2 published papers, one patient actually ended up in this group, did receive SABR for a solitary oligoprogression liver metastasis, and that patient remained alive and free of disease at the time of the second publication, and is still analyzed in the control arm. On the SABR arm, the patients also receive standard of care systemic therapy at the discretion of the treating clinician, but they also receive SABR treatment to all sites of metastatic disease, with the goal to control the disease rather than to just alleviate symptoms. And during the follow-up period, if patients in this group were to develop any new lesions that were amenable to more SABR treatment, they could still be offered SABR as salvage therapy. So in this group, actually 14% did end up receiving further SABR treatment after the first intervention was delivered, and 2 patients also received other forms of ablative therapies, such as microwave ablation and surgical resection. This slide is just for the radiation oncology just amongst us, just to show the dose and fractionations that were used in SABR treatment for the study, and they're quite similar to the ones that we use in our day-to-day practice. So between 2012 and 2016, 99 patients were enrolled at 10 different centers around the world, and randomized 33 patients into the control arm versus 66 patients in the SABR arm, with the primary endpoint of overall survival. So things to note about the baseline characteristics of patients in this study: even though breast was the top 4 most common histologies, it was still only 18% of the total study population, and there were some imbalances though with the 2 groups just to be aware of. So here, the prostate cancer patients, they were more dominant in the SABR arm, and also of the patients that did have 5 oligometastatic lesions, they were all randomized to the SABR arm. And just to also keep in mind that from a statistical method for this study, they designed it so that a finding of a p-value less than 0.20 would indicate a positive trial in the phase 2 setting, and that a finding of p-value less than 0.05 in this study could be considered a definitive positive result. So with that in mind, here are the survival, so Kaplan-Meier curves. On the left here, we have the overall survival curve for the control arm in blue and the SABR arm in the red. So you can see here visually, there's quite a difference there. So it was at 5 years, overall survival rates were 17.7% in the control arm and 42.3% in the SABR arm, with a p-value of 0.006. And so the median overall survival was 28 months versus 50 months, favoring the SABR arm. And so when we're looking at the number of patients that's left still alive at 5-year mark, out of the 2 that were in the control arm, 1 of them had breast primary, and out of the 10 in the SABR arm, 4 of the 10 were breast patients. And on the right, here we have the Kaplan-Meier curve of the progression-free survival, and you can see that at 5 years, the control arm didn't even reach 5 years, and so and a p-value was significant of 0.001. Just an interesting thing to note as well in this study, they actually did a post hoc analysis where they excluded the prostate cancer patients away from the group just to see if it made a difference, and they still found a treatment benefit in terms of greater 5-year overall survival in the SABR arm compared with the control arm. And they also did a post-hoc analysis on after they excluded the patients with solitary lesions, and they still found that the hazard ratio was in favor for the SABR arm for both overall survival and progression-free survival. But definitive conclusions can't really be made given the small sample size and that the analysis was not pre-specified, but it does reassure that the overall conclusion of the trial are not driven by those baseline differences that we talked about earlier. But ultimately, it's still a pretty small percentage of the total population were breast primary patients. So it indicates an early signal, but perhaps not strong evidence.
Yeah, maybe what?
I think someone's unmuted themselves, but that's okay. Now toxicities is really important to focus on in this study, because despite the stringent dose constraints and requirements for peer review of all radiation plans, there were still higher rates of treatment-related grade 2 or more adverse events in the SABR arm compared with the control group. And there were actually 3 grade 5 events in the SABR arm. So 1 patient passed away from radiation pneumonitis, and one from pulmonary abscess. I think they were non-small cell lung cancer primary, and the other one was actually head and neck primary with a lung metastasis. And the last patient passed away because they were undergoing surgery to repair a SABR-related perforated gastric ulcer, but developed a subdural hemorrhage. So that patient was a colon primary, and they were treating an adrenal metastasis. So quality of life data, long-term wise, there was actually no differences between the two arms. And interestingly, the cumulative incidence of new metastases was actually no difference between the two arms. So this suggests that the new lesions may have been already seeded before SABR was delivered in the SABR arm and grew in the months after randomization. And as I mentioned earlier, there was a substantial number of long-term survivors in the SABR arm that did require salvage SABR for their new metastases. And so in the scenario of having a longer median overall survival benefit, but short median progression-free survival in the SABR arm, it generally indicates that post-progression treatment has influenced the overall survival benefit. So conclusion of this study is that even though the SABR arm did show an overall survival benefit, most patients are not actually cured with SABR, but they do progress at some point with new metastases, and that safety should always be our first priority in terms of minimizing toxicity. And in practice, most radiation oncologists will compromise the dose to the target volume if there's any concern about the organs at risk. And so we're very eagerly awaiting phase 3 trials to confirm the overall survival benefits seen in this phase 2 study, and also to develop some biomarkers predictive of the benefits of SABR. So just to quickly mention, trials are currently undergoing recruitment. So phase 3 studies, here's a table. I won't spend too long on it because we probably want time for discussion, but there's quite a few that's coming. And just a quick mention of a local phase 2 registry study that we're doing locally is the AVATAR study, where we're looking at using SABR to treat oligoprogressive metastatic breast cancer, ER positive, HER2 negative, and seeing whether it influences time to change in systemic therapy. And quick mention about immunotherapy, there's a Boston 2 study that's coming, well, it's already completed, but published results are coming hopefully soon. And just to take home messages, so we're really in quite an exciting era as RADONCs in terms of expanding the role of radiation therapy. However, the evidence is definitely lagging behind the technology and the clinician enthusiasm, and we really do need to prioritize safety of patients. And so I think recruit patients to trials where possible, but if we do want to consider it, it has to be discussed and really need to follow safety guidelines. And although it's not currently standard of care, we're very eagerly awaiting phase 3 studies to give us more high-level evidence. And that's the end of my talk. Thank you.
Thank you, Janice. We made you rush there because we were running a bit late. So we've got a few minutes and we may just go a couple of minutes over. So if the panelists and speakers want to put on their camera. I'm going to take Chair's prerogative first, and I'll kick off with an easy question, and it's to both Kathy and Mike. So I think we've seen some data that in oligo progression, there's certainly evidence for local therapy. But I'm wondering what your considerations are, and maybe Kathy, you can go first. In a patient who's de novo oligometastatic disease, who the decision was to start on systemic therapy, and they're having a very good response at all sites. What is your thought about the breast at that point?
Yeah, it's a good question, Belinda. I historically was loath to jump in, but I think increasingly with so many adjuvant systemic therapies available, I'm very impressed with the response in the distant disease. And there's certainly some evidence in the mouse model that if you take the primary out, that there is a global immune sort of rallying, and you are probably doing a good job. So increasingly, I'm sort of impressed to take, particularly if it doesn't involve a mastectomy, if it's simply a lumpectomy, I'm very kind of persuaded in modern times to do that. And the other reason is some of the work that's come out of the genomics lab, where they've looked through the cascade rapid autopsy and next generation sequencing of tumours as the metastases evolve. You know, the change in the tumours that happen as you get more burden distantly makes it harder to cure these patients. So maybe taking the primary out at that very early time point is really going to change the whole course of history. But I don't really know is the answer.
And I guess, oh, yep, you go, Bruce.
Well, I agree with that almost entirely, but the only thing I would say is I don't only operate if there is evidence of residual disease in the breast. So in someone who appears to have had a PCR in the breast from the systemic therapy, I do not operate because I don't think a biopsy with no residual disease will help the patient. It may, I don't know that, but so I do some form of contrast imaging, and if there's a PCR, I'm happy to watch. But I do watch, and I would continue to see the patient, and if there were evidence of local progression, I would then operate. But that's a largely data-free approach.
And so I guess, Bruce and Kathy, I'll come to you, Mike, soon. So you've got your lady in front of you. She's got ER positive disease. She seems to have done well, but she still can feel the lump. And she says to you, look, I'd really want the lump out. And you agree to take the lump out. What are you going to do about her axilla that was node positive? Oh, Kathy, you're on mute. But I think you've said nothing.
I have said nothing. I think there's a big role for doing something to the breast. I think the axilla is very uncertain, and we know it doesn't change survival what you do to the axilla. So I just do the breast.
Okay.
Okay, I'm a bit different. If there's evidence of disease in the breast, in the axilla, I would take it out. Agree, and knowing that I don't know that that's making a difference. Often these patients have had a PET, and we have got access to a PET in this situation. If the PET showed activity in both sites, I actually don't see the logic behind removing half but not all of the local regional disease.
So you remove all the axilla?
If the PET is positive, then yeah, I would.
Okay. And Mike, question to you and Janice. So the residual disease, so there was that oligomet, let's say our first patient, she had a good going bone met, and then she's had a PET metabolic response. Would you still savour that?
Look, as Janice had already sort of said to us, the evidence currently is still not there. So it's not standard of care, but certainly the signals are pretty strong. We know that for favourable histologies like breast and even for prostate, patients do well. You do get a benefit in progression-free survival. So if there is a trial, discuss it at a MDM. If there's a trial, that's what we would prefer to do. But there isn't sort of anything in this country apart from the study that Stephen has for oligoprogressive disease. But if a patient's keen, if they are young, if there's only a limited number of metastatic deposits, if it's bone particularly, I have absolutely no hesitation in at least having a discussion with them, because we know we can do that very, very, very safely.
Okay. Carolyn Baker's got a question. I don't know whether you're on the voice or whether I can read it for you. Oh no, here she is. We might just, yep, great.
Oh, hi. I was just going to make a comment. So in the difficult patients, the morbidity from significant axillary disease is really problematic. And if you've got an opportunity for surgical resection to minimally debulk, I think I would agree with Bruce that that's important to do. The patient with, brachial plexus infiltration, intractable pain, flail arm, we're very limited in how we can palliate those. And if that disease has already persisted through your first and second line systemic therapy, it bodes poorly.
Mm-hmm. Mm-hmm. Thanks, Carolyn. Rob Tasevsky's got a question. At what stage would you operate if they're responding? Is it 6 months? Is it 12 months? Is it later? I've got a comment for that, but perhaps maybe that should go to Kathy or Carolyn or Bruce.
You don't want it to be progressing when you operate. And so you know if you've waited too long. So when is that? To me, it's after 3 months and generally by 6 months. But that's why 3 and 6, you know.
I mean, I guess I think subtype matters a lot here. That would be my comment. And it depends on how we're treating the patient systemically, assuming we go first. So, you know, for that lady, Rachel presented first with luminal disease, she could have had an endocrine maneuver up front, in which case we would be wanting to wait months to make sure that this was working. Bruce, the only exception I would have, I mean, certainly we do see, for example, some HER2 positive patients where, you know, they do extremely well in their distant sites and then they get some local progression, and we know that there's sometimes some heterogeneity. So, you know, that would be certainly somewhere we do come back to you and say, you know, we seem to be working for their liver and bone disease, but for some reason the breast has progressed. And we've certainly got anecdotal evidence that oftentimes the subtype has changed there. So
which highlights the importance of the multidisciplinary interaction, and also with radiation. You know, is there something that you can locally treat? And maybe the there are all sorts of options. We know that radiation is very effective for low volume disease in the axilla. You know, does that fit in? Yeah, so no hard and fast rules.
Javier's got a question. TNBC clinically T3 node positive and a single rib met on PET. They're PD-L1 positive. You're not making this easy. Would you offer neoadjuvant chemotherapy first? So it maybe is the systemic person online with Rachel. I mean, you know, I think drugs need to go first here because you've got a subtype where it's not only Yang has shown they didn't do well with local therapy, although the design there was that they needed to be stable for some months. So yes, we would go first. I mean, I'm thinking whether or not you'd try for a trial here of combination chemotherapy and immunotherapy, although that background is still very uncertain. You know, I guess the question also, Javier, is whether or not any local therapy might be relevant for this patient. Would you stereo that, Mike?
Oh, look, it probably depends on I totally agree with you. I think primary systemic therapy will be pretty important here. If the patient's going to declare themselves. If they have chemo-resistant disease, they're going to develop more mets and the horse is bolted. But if they do well, then potentially they're the patients that we should look at doing more, maybe like a regional therapy and also stereoing the rib.
So my hobby horse here, if that was found on PET, I'm really uncomfortable not treating them aggressively, because this may be the disease that previously would have been called stage 3 disease, aggressively treated with good outcomes. Just because something's found on PET does not mean it's the same stage 4 that has been stage 4, you know, for the last 30 years. But again, PET's useful if you, after initial systemic therapy, restage with PET. If, as Mike said, it's progressive, then local therapy is a waste of time. But if the PET has become negative, if there's a metabolic PCR, I think local treatment, and then it's exactly as Mike said, who knows, but if it were me, I'd want Sabre to the one side.
Yeah, and I mean, I think, you know, a little bit of time once they've stopped their systemic therapy or had a break is important too, because we want to see what actually we've achieved. And Carolyn's made a comment of the distinction between colorectal cancer, for example, and the resection of liver mets, you know, versus metastatic breast cancer. I mean, Caroline, if you're still online, but you might have gone, you're welcome to clarify that point, but I think we probably should state that given we did discuss that data today. I know we've gone a little over time. Is there anyone else with a burning comment or question? Are you just wanting to check your phone and see if we're in lockdown? Does anyone know?
Will be soon.
All right. Well, can I thank the organisers? Can I especially thank also our speakers, Janice, Yang, and Rachel, and Kathy and Mike, and of course always Bruce. We really appreciate it. We could have done this session twice. We've got a session coming up in the next couple of months of difficult cases, and any of you are willing to send us through a difficult case, we hope to have some very florid discussion. I think that'll be in July. All right, have a lovely evening. Thanks everyone again.
Thank you.